This is a challenging situation due to its rarity and also to the great variability of its presentation. I apologize because many things were already said by my colleague, Dr. Kasteman, but as he said, repetita iuvant. So I'll try to highlight the main characteristics of a type 2B von Willebrand disease, together with the modification of coagulation during pregnancy. I will present to you the data from the literature regarding von Willebrand disease and pregnancy and the possible pragmatic approach specific for type 2B. So we know that type 2B is characterized by discrepancy between the activity and the antigen, and the defective protein is characterized by an increased affinity to GP1B. Also, there is a loss of high molecular weight multimers, and thrombocytopenia can be present, especially in hemorrhagic episodes. So, during pregnancy, we know that plasma volume increases, and also for this reason, there can be a mild thrombocytopenia. Also, anemia can develop, and this can be worsened in case of iron deficiency. Coagulation factor, especially factor VIII and von Willebrand factor, will increase during the second and third trimester of pregnancy and will reach supraphysiological levels. So, specifically in type 2B von Willebrand disease, these two situations can interact so that due to the increased plasma volume and the increase of the defective von Willebrand factor, thrombocytopenia can develop, can worsen compared to previous pre-pregnancy levels, and we can have to deal with a severe thrombocytopenia that can go down to less than 50,000 platelets per ml. Platelet clumps can be visible in the blood films, and this is really a challenging situation. So, ideally, we should meet with our women before pregnancy to do the counseling. And we should discuss with them the transmission of the disease to the neonate, and also discuss with them the pregnancy risk in terms of risk of miscarriage and risk of bleeding during pregnancy, and risks associated with the delivery and during the puerperium, and also a possible bleeding risk of the neonate if he or she inherits the bleeding disorder. We are not alone in dealing with this situation. We work together with the geneticist to do the counseling regarding the inheritance of the disease, together with the obstetrician for the follow-up of the pregnancy and the anesthetist for choosing the anesthesia if this is necessary, and also together with the pediatrician who will take care of the neonate. And since here I put together the data from the literature regarding the miscarriage, I apologize for the busy slide, but I will highlight the what I consider important points. These papers cannot present big numbers in terms of pregnancies, and of course, numbers regarding specifically type 2B can be only very, very small. Most of the papers are retrospective, and in terms of a recall bias for miscarriages, I don't think this is a big problem, but other issues can interact with the risk of miscarriage, such as age, infection, genetics, or thyroid function, and these were not always considered in these papers. So I think that on the risk of miscarriage in patients with type 2B, we don't have an evidence, a clear evidence. Regarding just von Willebrand disease, I found very interesting this paper by Rezan Kadir, who found that some women with a uterine bleeding in the first trimester ended with a miscarriage. So this is something we must carry in our minds. Regarding the bleeding risk, the uterine bleeding risk during the pregnancy, we have different studies with different methodological approaches. I think that there is an increased bleeding risk, especially in the first trimester. This is not very strong, but of course, as Dr. Kasteman said in his talk, we are dealing with several types of diseases for von Willebrand disease. So type 2 can be severe compared to type 1, and this is something we must consider when we do the counseling with our women. And type 2b, there can be also a worsening of mucocutaneous bleeding in the third trimester, and this can associate with thrombocytopenia that is specific of this disease. So, tranexamic acid. It can be a very important tool we can use and have. We use it very easily out of the pregnancy. I wanted to review the data for its use during pregnancy because we know it crosses the placenta. And I didn't find that many studies. We have only case reports that reported no adverse fetal effects, but of course this level of evidence is not very good. I found an interesting recent paper that described 21 patients taking tranexamic acid during lactation. I wanted to report it because this is another situation when we want to use this drug. And the women were interviewed 3 years after the pregnancy lactation, and they didn't report any clinically relevant effects in the children. So I present here a possible pragmatic approach that is what we use for patients with type 2b. One thing that we are very careful about is to prevent anemia and iron deficiency throughout the pregnancy, because we want the women to arrive at delivery with good hemoglobin levels. And this is for 2 reasons. We want the women for virological reasons, because anemia can be a bleeding risk itself, and also if they have a moderate bleeding and they start from low levels of hemoglobin, they have a higher risk of being transfused, and we want to avoid at least this risk. In case of invasive procedure, it depends again on the levels of factor VIII and von Willebrand factor. In many cases, patients with type 2b have very low levels of both factors, so we should use the concentrate. And I think the DAVP should be reserved only to patients who demonstrated very good response and also absence of thrombocytopenia in a previous test. In case of uterine bleeding during the first trimester, especially if there are retroplacental hematoma that are not resolved by bed rest or progesterone, a short-term prophylaxis could be considered in these women. If we look at our pragmatic approach through the trimester, we want to see the patient at the beginning of the pregnancy to probably check historical levels of factor VIII and von Willebrand factor if we don't have a recent evaluation. We will monitor the full blood count and the iron state to prevent anemia and evaluate possible thrombocytopenia. And we keep monitoring during the second and third trimester these parameters. And at the end of the third trimester, at the 33rd weeks generally, we meet with the whole team to discuss the decisions we have to make and we consider the possible options. So here are the data from the literature regarding the risk of postpartum hemorrhage and delivery. Again, we have different studies. Some have large numbers, but they consider just the codes at this chart, so they will not have data regarding the type of von Willebrand disease and the levels of factor VIII and von Willebrand factor, and possibly also the treatment. But I think we can conclude that there is an increased risk of postpartum hemorrhage that is not too high in the first 24 hours, even because the hemostatic mechanism at delivery is also mechanical. So the problems associated with the bleeding disorder can be highlighted in the in secondary PPH when levels of factor VIII and von Willebrand factor go down. The mechanics are not so important anymore. And so we have to keep in mind that the secondary PPH is an important disease we have to prevent in our women. Here I collected the case reports specific for type 2B. They span a period of more than 30 years. They probably are the cases that physicians found more challenging and more interesting. I don't ask you to go through this busy slide. I grouped what I thought were the most interesting points for you. And you can see that delivery was, in half case, a vaginal delivery, in half case, a cesarean section. Thrombocytopenia is a strong issue. 1/3 of the cases that reported this parameter were less than 20,000 platelets per ml, and 2/3 had less than 50,000. 2 cases reported the use of epidural or spinal analgesia. One of these had a very mild, specific kind of type 2B, and this is something the current guideline advise against. So I think it's an important thing we have to discuss in our team. Platelet transfusion were given to half of the patients, and some treatment that was cryoprecipitate in the oldest cases, or concentrate or fresh frozen plasma, were given to all patients but one, and this patient did not present primary postpartum hemorrhage. Despite all our efforts, some bleeding was present in 2/3 of the cases, but was severe only in one patient. Here, bleeding was defined as a blood loss of more than 500 mL, but was severe, as I said before, only in one patient who lost 1 liter. So, if we try to analyze our patients with the same genetic mutations to see if at least thrombocytopenia can be forecasted, and this is we are disappointed in this, because with the same mutation we find patients with very severe thrombocytopenia and patients who do not have it. So I think this is, and also with this other mutation, we have the same data. So the considerations we have in our meeting: the kind of delivery. The vaginal delivery has a lower bleeding risk, but the risk of prolonged second stage labor with the possible use of forceps or vacuum is present. And the other problem is that with patients affected by type 2B, the use of epidural analgesia cannot be guaranteed. And this is something that women in our hospital nowadays request. So it's something we have to keep in mind. Cesarean section, on the other hand, has a higher bleeding risk, but we can plan the date and we can choose the expert operators. Regarding anesthesia, we already said that spinal anesthesia is in any case contraindicated if you have thrombocytopenia below 80,000 platelets per ml. But even if we have normal numbers, you have to keep in mind that you have to check factor VIII and von Willebrand factor levels. And the same and even more important is if you decide you can do epidural analgesia when you remove the catheter, you have to be sure levels are within the normal range. Regarding the concentrate, I will go back to the new concentrate, von Wende, that is already available in the US later. Nowadays, what we have, at least in Italy, is a plasma concentrate that contains both factor VIII and von Willebrand factor. They are different in terms of quantity of factor VIII relative to quantity of von Willebrand factor. What we use depends really on the levels that the woman reached at the end of pregnancy. Generally speaking, what we want to have is more than 100 ternational units for the cilater at delivery. That is not what would be a physiological level. This is something we have to keep in mind, but these levels are still very good at preventing a severe blood loss. And we wanted to maintain more than 50% in the first days. If you have the possibility, you would wish to evaluate peak and trough levels of factor VIII and von Willebrand factor to decide which doses you will use after the first. And we generally associate tranexamic acid. For a normal weight woman, we use 1 gram intravenous before delivery, and we keep using it orally every 8 to 12 hours in the following days. We would associate platelet transfusion if cesarean section and platelets are below 50,000, or below 30,000 if we choose a vaginal delivery, or in any case of bleeding. What I must say is that the recovery of platelet number is not always good, and this can be due to the release of the defective von Willebrand factor during delivery. So from the pragmatic approach, what do? We write a very detailed medical report, we share it with the team, we share it with the patient. In the written report, we give a specific indication regarding the delivery. If we choose a vaginal, we will write an advice against prolonged second stage labor. We will describe the type of anesthesia we would wish to use, the dosage of the concentrate and also of the tranexamic acid. We write an advice against the use of a non-steroid anti-inflammatory drug and aspirin for pain control, and we will bring the concentrate to the delivery room together with a copy of the written report, so everything should be there when the woman is ready to deliver. Together with the pediatrician, we also write what to do for the neonate, and we generally recommend to give oral vitamin K and vaccines by the subcutaneous route, if it is possible to avoid intramuscular injection and venipuncture, and also we recommend caution with heel sticks. And since many of our women have a genetic characterization, if it is possible, we collect cord blood for diagnosis of the neonate as well. Even if, of course, this is not something mandatory, and also it's something we can do in our center, but it's not really necessary, I must say. Regarding the puerperium, for this, we know that the risk of secondary PPH is 10-20 times higher, and we want to continue monitoring this situation, because in case of bleeding, the bleeding can be really massive in some women, and so we want to prevent it. The frequency and the type of follow-up will depend on basically on hemoglobin at discharge, but we also try to inform the patients very well that if bleeding or loci are excessive, they must come themselves to the center to be checked. We have no data on thrombotic risk. We never used in type 2B any heparin, even in women who were older, like 40, and had a cesarean section, because we don't feel we can risk a secondary PPH at home. So going back to our first slide about the counseling before pregnancy, I think when we see women with type 2B, we can explain very well the transmission to the neonate. We cannot give specific data on the risk of miscarriage. We can say that there is a possible increased risk of uterine bleeding during the first trimester. If they have it, they have to report it as soon as possible, so we can deal with it. There is an increased risk of postpartum hemorrhage during delivery and the puerperium, and there is a need of an expert team at delivery. Regarding the neonate, there is a possible, but I would say low risk of bleeding at birth in our experience. So, looking at the future, Vonvendi is the new concentrate that is already available in the US. It's recombinant. It contains high molecular weight multimers. The problem is the timing of administration. Since it does not contain factor VIII, it will depend very much on the woman you have to deal with. And with the levels of factor VIII, she will reach at the end of the pregnancy. So it is easy to decide if you need to give a factor VIII as well at delivery. If you decide to go for a cesarean section, it will be really challenging if you have a vaginal delivery, because this drug will increase your patient factor VIII only after 6 hours. So you have to decide if you want to give together with this concentrate also a dose of recombinant factor VIII. And finally, I would be very interested to see data in the literature regarding the use of thromboelastogram, such as TEG or ROTEM, in patients with type 2B to evaluate the role of thrombocytopenia in these patients. I didn't find anything in the literature, but I would be interested. So, just final slide. Type 2B is really a challenge for any physician. Available data from the literature are scanty, and they reflect also the profound changes of the clinical practice. For sure, they require an expert team during pregnancy, delivery, and puerperium. So I thank you, and I look forward to the discussion.